Hello and welcome. I am thrilled about tonight because we're talking about things that are interesting and relevant. And we are going to be discussing, a new book called Vaccine Hesitancy, Public Trust, Expertise, and the War on Science, which I wish it was not as topical as it is, but it is as topical as it gets. Thank you for being here tonight. Thank you for continuing to want to learn with the library and with our guests during this godforsaken pandemic that has lasted now a year. And we're deeply appreciative of people coming and joining and staying informed, and we're just so happy. So thank you very much tonight. We are doing this event tonight with basically my favorite thing at the University of Cincinnati, and maybe in Cincinnati itself, the Center for Public Engagement with Science. I just so happy we have one. Every time I think of it, it brings me joy. The founding director of the center is my friend, Angela Potochnik. Angela, thank you very much. And please take it away and introduce Maya. And I can't wait to listen and learn. Thank you both very much.
Thank you so much for the generous introduction, John. And it's really great to be here. I've already lamented a few times. I wish that we were in the beautiful mercantile space in person, but soon enough, I know. So as John Faherty said, I'm Angela Potochnik. I am a professor of philosophy at the University of Cincinnati, and I also direct the University of Cincinnati's Center for Public Engagement with Science. So very briefly, I'll tell you what that is. Our center is a network of UC faculty and students that works collaboratively and also in partnership with other local organizations like the Mercantile Library to expand and enrich the interface between science and the public to the benefit of all stakeholders. We are thrilled to work with the Mercantile Library on tonight's event, and especially thrilled to be having a conversation with Maya Goldenberg about her recent book. So I want to mention also that this event is also co-sponsored by the Philosophy of Science Association. This is one thing that Professor Goldenberg and I have in common. We are both philosophers of science, and our professional organization is co-sponsoring this event. I'll start by saying a bit more about Maya Goldenberg. Dr. Goldenberg is an associate professor of philosophy at the University of Guelph in Ontario. So she's joining us from Ontario tonight. Her research addresses the fundamental question of how we know what to believe, and then especially how we know what to believe in healthcare, regarding healthcare in particular. Professor Goldenberg's book, Vaccine Hesitancy, Public Trust, Expertise, and the War on Science, was published just earlier this month. I think we're a couple of weeks after the publication date. And that came out with the University of Pittsburgh Press. All right, so I'm going to stop with that brief introduction and jump straight to my questions for Dr. Goldenberg. To start off, Professor Goldenberg, can you tell us why you turned your attention to the topic of vaccine and vaccination and vaccine hesitancy?
As a philosopher of medicine, I'm interested in how evidence and arguments are operationalized in order to justify knowledge about health and healthcare. So my interest in vaccine hesitancy really started not long after I'd read an investigative journalist's expose of Andrew Wakefield, who is the lead author of that notorious study linking autism to measles, mumps, and rubella vaccine. This study had already been criticized and retracted at the time, but this report had the new finding that he had indeed fabricated his data. And it was commissioned by and published in the British Medical Journal in 2011. And the level of misconduct that it detailed was really breathtaking. So I thought, as many people did upon reading this, that the autism vaccine thesis was going to end right there. So vaccine hesitancy, for the most part, was going to end. And of course, it didn't. Measles outbreaks continued. Pediatric vaccine hesitancy has continued. And I wondered why this was the case. I mean, we have this strong consensus on vaccines. It's been strongly communicated to the public. In industrialized nations, those vaccines are very accessible. So why is it that some people hesitate? The dominant view at the time, and what is still the case, is that these parents do not understand the science. So if we just provide the missing key pieces of evidence, they'll be convinced. And so I thought that was the case. I had no reason to think otherwise. And given my area of research, I thought I was in a good position to find out what that missing piece of information was. I soon realized I was asking the wrong question. It wasn't about some missing piece of evidence or lack of scientific literacy that drives vaccine hesitancy. And that's when the research got very interesting.
Thank you. So that from there, I'm going to ask a really basic question, and I hope that's okay. I want to know what you mean by vaccine hesitancy. So this is the new term. I hear it everywhere, but honestly, I don't remember hearing that term, say 5 years ago, something like that. So what is this, and why is vaccine hesitancy the focus of investigation?
So it's distinct from the behavior that you might be interested in, which would be vaccine refusal. And it exists along a spectrum. You can have people that are slightly vaccine hesitant, and you can have people along the other end that are very, very resistant to vaccines. And probably about 8 years ago, public health research shifted towards vaccine hesitancy. Namely, the idea was that you have to keep an eye on the attitude, not just the behavior, in order to protect public health. It encompasses a much wider swath of the population. By some estimates, 40% of American parents with young children have some degree of vaccine hesitancy. And knowing this and knowing where it comes from helps tailor public health outreach towards parents. So if you only look at refusal, you're going to miss a lot of what's going on in terms of public attitudes around vaccines.
So you've told us how you got interested in the topic of vaccination, vaccine hesitancy, and why we should be thinking about vaccine hesitancy, this sort of taking into account attitudes versus just behaviors, which is a really helpful starting point. So from there, I'm wondering if you can say something more about how you were sort of touching on this. I feel like as you focused in on sort of young parents in particular, but can you say something about how people's communities and social identities might influence their degree of vaccine hesitancy, make someone more likely to be vaccine hesitant or not?
So as I moved away from science illiteracy as the explanation for why vaccine hesitancy occurs, I brought in an alternative thesis. And the idea was that it's got to do with public mistrust of scientific institutions and government agencies that manage our health and safety. Social identity and community membership largely shapes any one of our relationships to the system. So people trust vaccines to the extent that they trust the system that develops, regulates, and legislates vaccines. So this point bears out in the survey research on vaccine hesitancy. For example, in a global survey of COVID vaccine acceptance that was published last summer, survey responders who said they would likely or definitely get the vaccine, the COVID vaccine when it became available, were also polled in that same poll as more trusting of the government to manage the pandemic. So the two went together. And that's not just in the USA. And we've seen this in other healthcare crises like the H1N1 pandemic in 2009. People were more likely to get the vaccine if they trusted the government to manage the pandemic. So that's something. Now, members of racialized and otherwise marginalized communities are far less trusting of the government and of healthcare systems. And they have good reason to be wary. The healthcare experiences of racialized Americans are a lot poorer than non-racialized Americans. And these communities, as one would expect, have expressed less willingness to get the COVID vaccine. I should add that it's only recently that public attention has been directed at the connection between social identity and vaccine hesitancy. In the pediatric vaccine research world, there was and still is this persistent view that vaccine hesitancy only exists among white affluent mothers. Now, my research showed that this was false. This conclusion was incorrect. And even here, these white affluent mothers who hesitated about vaccines were not recognized for what they were doing as airing grievances about the healthcare system vis-a-vis their social location. They were assumed to be selfish and confused and overly emotional. And these, of course, are deeply sexist characterizations of women, and they also allow women's concerns to be ignored.
Okay, so I'm going to follow up in a minute to ask more about the themes that you develop in your book on sort of your account for vaccine hesitancy. But before I do that, I want to take a step back and ask another biographical question and sort of a what do you bring to this project sort of question. So I mentioned to everyone at the front end that you and I are both philosophers of science. We think about science, right? We spend our time thinking about how science works and how that fits within society, but we don't practice science. We don't do science. And philosophers of science also don't, at least typically, collect data about people's beliefs or study why people believe what they do or act the way that they do. So on the front end, there's sort of this puzzle of why someone like you would be writing a book like this or talking about a topic like this. So I'm really interested to know something about, and to have you share with everyone, something about how you see philosophy of science in particular contributing to research and outreach, for that matter, bearing on vaccine uptake.
Oh, what a good question. I'll say this. I think it was my training as a philosopher that led me to challenge the dominant framing of vaccine hesitancy as a problem of scientific misunderstanding. So the strongest articulation of this view of scientific misunderstanding being the cause is that there is a war on science, a culture war on science, really. So I did what philosophers do. We evaluate arguments. And upon evaluating the arguments for the war on science, namely what evidence was presented in the empirical research, what assumptions were made, which values were at play in characterizing the phenomena, I could see that the popular explanation did not hold up to scrutiny. To start, there was inconsistent evidence that proponents of the war on the war on science tried to explain away, tried to sort of account for. For example, vaccine hesitancy is recognized to not correlate with levels of education. So it is not the case that people who are less educated are more vaccine hesitant. Instead, some of the strongest vaccine hesitators, and certainly the most vocal of them, are highly educated people with bachelor degrees, even postgraduate education. So here, commentators would come in and say things like, oh, a little knowledge is a dangerous thing, and they would label it a Dunning-Kruger effect without further exploration and justification for this claim that people indeed overestimate their expertise. So I found that the theoretical framework was the problem. The war on science is based on a mischaracterization of how people incorporate scientific information into their beliefs and into their healthcare decision-making, for sure. There's more to it than understanding the science and then people vaccinate. Here is where trust came in. That was my alternative theoretical framework. And I thought it would better explain how people interact with scientific information, how they process it, how they prioritize it as a potential reason for action, maybe vaccinating their children, and also who you consider an expert source of information. And that new shift, that theoretical shift to a focus on trust, also made me look at why it was that racialized communities who are known to be less trusting of healthcare would exhibit less vaccine hesitancy than non-racialized people with more privilege. And that seemed strange given what we know about trust in healthcare. And here I found a gap in the research literature. People of color were largely missing from most of the empirical research measuring vaccine hesitancy. I suppose the war on science framework didn't demand active recruitment of racialized people in the studies. So a lesson here, so where philosophers of science come in, a lesson here is that you need good theoretical orientation for high quality scientific research. And philosophers of science are actually good contributors for that goal of robust theory to guide empirical research.
That's really interesting. Thank you. Okay, so you've given us these two terms to work with already. You've told us about war on science. This is the sort of old bad framing, or inadequate framing, I should say, a little less cavalierly, for an explanation for vaccine hesitancy, and then the crisis of trust framing that you adopt in contrast to that. So I want to ask more about that. First of all, about both of those ideas, right? How would you summarize the difference between the war on science framework versus the crisis of trust framework? And then I also want to ask what that word is doing, the word framework there. I really like this sort of introduction of the idea of framework as a way of opposing these two potential explanations. But what is it? What is the significance of introducing these as frameworks?
Well, frameworks are the theoretical grounding or the background that shape how we understand an issue. And that understanding will, of course, influence how we respond to it. So when we look at the values and assumptions that are at work, and then we can consider if they support the best explanation and shape the best response. So I found difficulty with this thing that I called a war on science framework, namely this situation of vaccine hesitancy within some kind of problematic relationship between the public and science. So here, either the public misunderstand the science due to poor literacy or because they've received misinformation, or they deny science and they ignore scientific experts. And the thinking here is that if we can correct that misunderstanding, everyone would accept vaccines. So I'll say that idea that it's a problem of information deficit drives almost all vaccine communications directed at the publics. If you look around now for infographics about vaccines and COVID vaccines for sure, but prior to this with influenza vaccine and pediatric vaccines, you usually get documents that say things like just the facts about vaccines, separating fact from fiction, or debunking myths about vaccines. Most communications look and sound something like that. Yet those interventions have had very little impact. This has been tracked, of course, that vaccine acceptance and refusal rates have changed very little over the decades, even in areas where there's been a lot of this kind of fact-based public communications. We even find vaccine hesitancy has been slowly rising regarding childhood vaccines. So this should suggest that the outreach efforts are not hitting the mark. And I'm saying that there is more to vaccine hesitancy than information problems, and that's why it's not hitting the mark. Sure, misinformation is a problem, but that corrective where you ply people with the facts is far from obvious that it's going to work. Instead, the very willingness to question consensus claims or to entertain online information and wild-sounding theories that you read on the internet stems from a problem of poor trust. So there's a strong research basis in philosophy of science and social psychology into the ways that we come to know things via our trust in others as expert sources. And this is important to hear. We rarely learn things for ourselves, where we study the issue at length without consulting others and draw definitive conclusions. We rarely do this because there's really just too much out there that we need to know. And we often don't have the skills to fully study the issue independently. So instead, we commonly rely on cues or heuristics from other people. We look at those who we know to be trustworthy as informants, people with people with information who we trust as informants. So the term for this is epistemic trust, and this trust in others assists us. All of us, no matter how educated we are, in knowing most of the things that we know. So vaccine hesitancy can be understood, and I'd say it should be understood, as a breakdown of those trust relationships where members of the public look towards conventional experts like doctors or nurses or public health officers for advice about vaccines. Something has gone awry in those relationships such that some people no longer trust the usual sources for healthcare advice. And it is that trust breakdown that needs to be addressed. If we don't, it won't matter how many fact sheets on vaccines you provide. Vaccine hesitators do not trust the source of that information. And I should add that this isn't just theoretical speculation. The sources of mistrust are identified by vaccine hesitant people when they are asked why they hesitate. In the social science research, parents commonly talked about being unsure about vaccines because they don't trust the pharmaceutical industry's influence on health research and healthcare practice. They think the profit motive puts people at risk. And this point comes up again and again. I've already mentioned that members of marginalized communities don't trust the system, whether that's the healthcare system or broader systems of governance. And they express this mistrust when they've been asked in recent polls about whether they want to take the COVID vaccine. In response, Black Americans frequently bring up Tuskegee. Of course, that's that infamous and deadly research study that was carried out by the U.S. Department of Health and Human Services on Black men without their consent for decades. And there are other cases of research undertaken on racialized immigrant and otherwise marginalized communities. So even today, people of color say, I don't want to be a guinea pig for the government, recalling that history and not knowing whether we've passed that dark history yet.
Oh, that's fascinating. Yeah, so it's sort of, I'm beginning to better understand how it's too sort of pat of an answer to talk about the credibility of the science behind vaccination and stop there, something like that. So there's another theme, or at least a point that you pick up on in your narrative that we haven't talked about yet that I'm also really intrigued by. There's a role, it seems like, in your narrative played by appeals to democracy, and really actually on both sides of the issue of vaccine hesitancy. So on the one hand, you discussed how pro-vaccination efforts have tended to equate embracing scientific findings with democratic ideals. But then on the other hand, you've also talked about how some concerns about democracy actually are some of the ideas that seem to motivate at least certain varieties of vaccine hesitancy. Can you say more about how you think appeals to democracy have featured in this debate?
Oh, there's so much in that question. Okay, I'll start with this. In the war on science, there is a heavy moralizing of science as the steering path towards truth and rationality and general social well-being. We've seen this during COVID as political leaders around the world promised to follow the science as some kind of promise to the public that they'd do the right thing in terms of COVID response. Now, follow the science is more rhetorical than substantive because the science that they claim to follow was emergent. It is heavily contested, and sometimes we even have contradictory statements that both count as science. No matter, because science is supposed to save us. So that's an example of that kind of language. Science is also supposed to bypass political partisanship. We're not supposed to argue with facts, and any effort to do so has been called post-truth. That's a contemporary word. And with that, we've had this tangle of social unrest regarding the status of experts, the status of the media, and things like that. So science and facts and truth are supposed to guide democracies. Otherwise, majority rule would lead to irrational policy choices. And that's why the rhetoric of people being anti-science because they don't trust vaccines or otherwise gets to such a feverish pitch, because there's that feeling that society as we know it will fall apart. Now, it's worth knowing that the opposing insistence by the refusers that say things like experts are elite or mainstream media promotes fake news, that challenges the very idea that facts stand out as plain and for everyone to see. Instead, facts are imbued with values, and those challenges to the so-called scientific facts are being made by people who say the values that govern things like public health response to a pandemic are not the values that they hold. So we commonly get into arguments about whose science is right, who's got the facts, and all the while, it's actually the values attached to those factual claims that are being contested. People are challenging what policies and practices will follow if you accept those facts as true. How will they impact one's livelihood, one's community, and so forth? And those are actually concerns about democracy too.
Thank you. That's fascinating. Okay, so whenever we hear about vaccine hesitancy in the news, it seems like it's in the context of social media. And I think you've already referenced sort of what will cause someone to turn to some sort of shady thing that's linked to, or suspect source of information that's linked to on Facebook or Twitter, something like that. And Facebook and Twitter are sometimes blamed, it seems, or focused on really a lot, especially recently, for helping to spread disinformation about vaccination in particular. How does social media fit into your analysis?
I agree that these platforms create a lot of problem by amplifying disinformation. But I'm going to say this, blaming social media misses the cause. We need to ask, why do people seek out information online? People who probably know that the information that you get online is varied in terms of quality. Why is it that conventional sources are not enough to satisfy their informational needs? We especially need to think about people in communities with low trust in expert institutions. These people in communities struggle with health decisions because they have this informational vacuum. They don't trust the experts. They need information, so that need gets filled by whatever is circulating on WhatsApp. And that creates difficulties for making informed choices and making good choices for you and your family and your community.
Thank you. I feel like I might be able to predict where you'll go with this question based on your answer to that question, but here we go. So in the third part of your discussion on the war on science, right? This is the old framework that you're replacing with the crisis of trust framework. That focuses on the idea of death of expertise. This attributes vaccine hesitancy to the belief that no one listens to experts anymore. So you give the analogy there, a really nice analogy of the public preferring peer-generated recommendations from Yelp over the expertise of a Michelin guide, something like that. So why is this, the death of expertise, an unhelpful or wrong way of thinking about vaccine hesitancy?
Oh, thanks for asking about the death of expertise. That term, the death of expertise, was coined by the American political scientist Tom Nichols. He wrote a magazine article and then subsequently a book by that name, The Death of Expertise. And those works described how nobody listens to experts anymore. It is supposed to explain why patients challenge their doctors on vaccines, which is a problem because doctors clearly have more expertise by virtue of their healthcare training. The death of expertise is also supposed to describe an epistemic leveling where everyone has equal expertise on all matters. So following the death of expertise explanation, a patient can spend time doing research on the internet and they assume they're in a position to challenge their physician. That's what the death of expertise is describing. And I think there is problems with that, problems in how the phenomena of interest is being described. So I'll start with regarding patients who challenge their doctors or try to bring in new information, maybe things they read on the internet or otherwise. This is a very uncharitable view of why patients bring alternative points to their physician's attention. It does not need to be because they think they have similar medical expertise. It can be because they think their lived experience, something that doctors do not share with them, they think it provides relevant information that their doctor, the expert, should consider. And that's consistent with most ethical models of patient care, where the patient provides a legitimate voice and even legitimate information in collaborative healthcare encounters. But back to vaccine hesitators and refusers being anti-expertise, I think this is false. If anything, we can see a proliferation of experts. Some are unconventional, but they are regarded as experts nonetheless. So vaccine skeptical communities, whether online ones or ones that are geographically situated, will frequently appeal to experts. They especially hold up trained scientists and physicians who challenge the vaccine orthodoxy. Andrew Wakefield is the exemplar of this. He is much loved and appreciated by his loyal followers, largely because he has the epistemic credentials. He's understood to have the knowledge, and he's valued because he has what they see as good character. They see him as brave enough to challenge the orthodoxy, to speak truth to power, no matter what the cost to his reputation and professional status. Now, other expert sources that are valued in these communities are not classically trained. They may not be scientists or physicians. Their credentials might lie in their character, perhaps their outspokenness, their dedication to defending children, for being good mothers that do the research and defy paternalistic norms of doing what the doctor says they should do. So that's where their expert status resides, these unconventional experts. It is surely a sign of poor public trust that the hierarchy of expertise has been inverted. It was usually the case that the highest level of expertise is attributed to that credentialed person who's closest to the research community. So being a scientist, of course, gives you status, but being a scientist in the CDC should give you even more status as expert. Now we've got the outsider status being regarded as more trustworthy because the insider community, let's say the CDC, is seen as either corrupt or untrustworthy.
I'll say that I'm better understanding how crisis of trust versus war on science are frameworks, right? So you have this way of reinterpreting the same phenomena in these very different ways. So let's talk a bit more about the crisis of trust framework. So you highlight 5 areas to which the crisis of trust framework can be applied. These are encounters between healthcare providers and patients, one situation you were just talking about, public health messaging, vaccine mandates, diversity, inclusion, and representation in health sectors, and finally, industry influence on healthcare. Obviously, we can't discuss all of these today. We're running too short on time, and I encourage everyone in the audience to read your book to learn about each of these in turn. But could you speak to us at least about how the crisis and trust framework can be applied to 1 or 2 of those areas?
Sure. I'll start with the first one. I spend some time talking about how encounters between healthcare providers and patients could go better. Healthcare providers are still the most trusted sources of health information. Even people who largely don't trust the system, they often trust that personal connection and the face of their provider. So these encounters with, let's say, a vaccine hesitant mother could go much better if physicians made a point of listening attentively rather than demonstrating impatience. It is not uncommon for this narrative to play out in the research that I read, where it started with a mother who had questions, went to see her pediatrician, and got shut down and was made to feel stupid for asking questions. I know doctors feel rushed and sometimes uncomfortable having these conversations, but their role is really important for sort of shaping the health of this baby. You're more likely to have an impact on other person's thinking if you treat them with respect and take their concerns seriously. So physicians would do well to start with the position that says something like, "Mom, you and I both want what is best for your child." So by doing that, you legitimate the patient's status as a caring parent, and a better dialogue can follow from there. And hopefully an informed decision about vaccines also follows from there. Now, I've just described a much better healthcare conversation between patient and provider, but there are more structural obstacles to those conversations going well because although people trust their healthcare providers, those providers are situated within institutions and institutional framework that are not always trusted. So doctors really can't say much about financial conflicts of interest in biomedical research, and they shouldn't have to. Those conflicts need to be better managed so that the publics aren't as concerned about them and don't have these kind of misgivings about what should be very equitable and positive encounters with their healthcare provider. Now, there's also the issue of how the healthcare system works vis-a-vis racialized groups and people. And these healthcare training programs can do a lot more to improve the healthcare experiences of racialized Americans. Major resources could be put into anti-racism training in all training programs. There should be active recruitment and retention of students, as well as faculty of color, in order to have a better representative workforce. This is how you build bridges with mistrusting communities. You have to make the effort and earn that trust rather than assuming that you should have it.
Thank you. Okay, so we've gone most of this whole time without talking about the elephant in the room of COVID-19. And so to put you on the spot, how do you see all of this bearing on or playing out in the context of COVID-19, in the context of current circumstances?
Well, I think the major themes that I addressed in my research, public trust specifically, and the public's relationships to experts and expert institutions, actually seem to have been amplified in our COVID situation. Here we have this unusual situation where our public health officials have become household names, whether they're admired or maligned. Also, COVID response we're seeing is often aligned with ideological views. So in the United States, masks, business and school closures, even case counts were highly politicized, and acceptance of these policies, public health policies, and acceptance of the science that supported them correspond with political and ideological leanings. And that's the same with vaccine acceptance too. So the polling currently shows that vaccine resistance is highest among communities that don't trust the government. So that's either due to the historic injustices that I've mentioned already, and also among those groups that think your past federal election was rigged. So this is the social and political context that I've been describing and claiming that it shapes vaccine attitudes. And I think COVID is actually making that more apparent if it wasn't already apparent before.
Interesting. Okay, so everyone, audience, I'll mention that I have one more question. Then I'm going to pose the questions that you ask. Okay, so this is my last question then. Beyond vaccination efforts, there have also been many other flashpoints in how science relates to politics over the last several years. And I think you actually referenced some of that in discussing COVID-19 as well. What lessons do you see from your research in this book for other situations in which the public interfaces with science?
I think there's room to put trust at the center of research programs on public attitudes towards a variety of politically divisive science policy issues. So my work was demonstrating how putting trust at the center of understanding vaccine hesitancy does a lot of good conceptual and even empirical work. So I'd like to see where what would happen if we put trust at the center of other areas of public discontent, figuring out where discontent lies and trying to address those issues rather than assume that the publics are mistaken or misinformed to the extent that they refuse the scientific consensus.
Okay, thank you. It's nice to imagine sort of how that broadens out, I guess, along lines of sort of shifting this framework of thinking from expertise to a focus and sort of facts to a focus on values and trust, and how that could be involved in other sort of science politics debate as well. So as promised, I'm now going to turn to other people's questions. The first one is from Vanessa Carbonell. We are hearing that in some places, high proportions of healthcare workers themselves display vaccine hesitancy, including nursing home staff. Does this mean that they don't trust the very same healthcare system that they work for? I wonder how they reconcile that and whether they are ambivalent about the care they provide within that system.
Very good question. That has certainly been an interesting phenomena, looking at how healthcare providers have been resistant to the vaccine. I think that can be explained in a number of ways. It doesn't mean that healthcare providers are dismissive of healthcare as a whole. It means that they're not fully sold on this vaccine. And that can be for a number of reasons. One is they might have the same concerns as many members of the public do. First, that these vaccines are new, and therefore there's a lot we don't know about it. The worry that maybe it was rushed, the same concerns about financial conflicts of interest. Healthcare workers are not immune to those kinds of concerns. Also, healthcare workers that belong to racialized communities that are mistrusting of healthcare. That is still present. I know sort of anecdotally that the largest amount of healthcare worker resistance is coming from long-term care workers. And we know that that workforce is largely immigrant and racialized women. So they bring a lot of the concerns that I've already brought up, just as members of communities that are not always treated well by the healthcare system, and also might be feeling ambivalent about their trust in government because they were not adequately protected during this pandemic. In fact, they were among the most at risk when they couldn't do things like access adequate PPE, and they are chronically understaffed and underpaid, and they could not take care of their patients. So they bring those frustrations out and those concerns, and it gets tied into vaccine hesitancy. Another feature is that we've got the unknowns. Some of them are more pronounced than others. A lot of this workforce are women who are of childbearing age, and they want to know more about how these vaccines impact fertility and conception and pregnancy as well. And the standard now in health research is often to keep pregnant women out of clinical trials because of fear of that it could be dangerous for the fetus. However, it leaves this gap in knowledge where women are now being told to go ask your doctor if you are pregnant or planning to be pregnant to see if the vaccine is right for you. All the while, the doctors don't know anymore because this hasn't been researched. So the gaps in information are impacting the people who are at the front line of the outreach. They're the ones that need to make the difficult decisions and don't get to sit back and say, maybe I'll get vaccinated, but I don't want to be the first to find out, or I'll wait and find out if, say, pregnancy and fertility are not impacted by this vaccine. So they're put in a difficult position.
Thank you. So here's another question from Eduardo Martinez, who asks, how would you counsel individual physicians or healthcare providers more broadly to engage with vaccine hesitant patients in light of your epistemic trust diagnosis? Is there a danger of putting too much or too little responsibility on healthcare providers?
There is so much tied into the importance of these healthcare encounters. I mean, prior to COVID, most people got their information from their healthcare provider. And so it's largely one-on-one talks between, let's say, expecting mothers and their physicians. And it is well known that family doctors are not remunerated adequately, and they just don't have time to have these conversations, which might involve multiple conversations. It can be time consuming to build that kind of trust and break down the kind of resistances that might need to be broken down. So I think family docs certainly deserve more support to do this. I'll say that. All the while, they're so important that that's exactly why we should be supporting family physicians. There's a lot of literature on how to talk to patients, and it usually says be trusting, don't be judgmental, hear them out, but that takes time, and physicians deserve to have that framework where they have the time to have these important conversations. Now, a new thing in COVID is because we're not having the kind of one-on-one interactions with our physicians unless absolutely necessary, there's been a lot of work by grassroots organizations offering webinars and Zoom meetings targeting populations that they think need a little more time and understanding around vaccine conversations. So there's been groups that sort of do offer, let's say, nightly Zoom webinars for personal support workers or members of racialized communities gathering their local talent, doctors or scientists from these communities that can provide culturally sensitive information and safe feeling settings, linguistically appropriate if they speak other languages. And more than anything, people are getting information from people who they see as trustworthy. So a member of your community, if you are from a racialized community, seeing people who share your history and share your values and come from your community are going to be more trusted than this sort of anonymous face of public health.
Here is a question from Abel Gustafson. He asks, when is factual information beneficial? So the science communication literature frequently derides the knowledge deficit model, the idea that the cause of the anti-science positions is a lack of knowledge. However, surely for some issues and audiences, good, clear information is what's needed. So there's some nuance here, and maybe we shouldn't assume that educational campaigns are ineffective, nor should we say that facts fix everything. And he's interested to hear your perspective on how to strike that balance.
Good question. My answer is that providing accurate information is absolutely necessary, but it needs to be couched within the context that vaccine hesitators are coming at it. So if you actually sit down and talk to people about why are you hesitant about vaccines, you're going to hear a variety of reasons. And some of them are lack of knowledge or lack of clarity. And that's where an informational intervention would be helpful, but it needs to be crafted to the source. If it is general mistrust writ large, then the information isn't going to help. In fact, it might create defensiveness. If it is legitimate informational questions like of the sort of, well, I heard mRNA vaccines change your DNA, that's somewhere that you could direct towards accurate information. But you also might ask what they see as the sources of accurate information, because it shouldn't be surprising that some people say anything offered by the CDC is suspect to me, and that's because of a variety of sort of lived experiences that make them feel that way. So what can you do to package the information that they need in a way that they will find amenable? Because in the end, they are looking for information and they need it. They deserve, vaccine hesitant people deserve accurate information as much as people who are not vaccine hesitant.
Okay, thank you. The next question is from Vivek, who asks, how can public health messaging in particular change to improve vaccine hesitancy?
I've looked at some research on how pediatric vaccines are marketed, and there has been a shift since the early 20th century to frame it as a personal health decision. Prior to this, and this was back in the days of the smallpox vaccine, it was framed as something you did to benefit your community. And at some point it got shifted towards the personal health decision. It's usually aimed at mothers, trying to convince mothers, this is what good mothers do. You vaccinate your kids to protect your kids and protect your family. And it's been noticed that that is somewhat helpful. I mean, if you convince enough mothers that that's what good mothers do, then you will get a high degree of coverage. But it really misses the power of many of our best vaccines, which is the community protection. So public health messaging that emphasized the collectivity or the community aspect of vaccines is an interesting turn that might actually inspire a little bit more community thinking overall. I know that's not a popular view, but it is definitely part of our sort of educational infrastructure that we could, let's say, teach children more about taking care of each other rather than liberty and taking care of yourself. And vaccines are actually a way of initiating that conversation. What is it that we want to do to help each other, with the idea that everyone benefits if we're all taken care of?
Our next question is from Alyssa, who asks, is there a danger in citing vaccine hesitancy when we see lower numbers of vaccinations among people who have been systemically oppressed, when there might be other confounding and racist factors that need to be brought to light and addressed, such as lack of equitable access, for example?
I understand, and I also argue it pretty strongly that in my work that vaccine hesitancy is a signal of exactly the things that you're pointing to. So all kinds of poor relationships with healthcare, with systems of governance. And because of that, talking about vaccine hesitancy doesn't need to be understood as minimizing it. Instead, vaccines have been sort of packaged in ways over the years that they always represent much more than vaccines themselves. They represent a lot, including how people feel connected with systems of governance. So I don't think there's any harm in focusing on vaccine hesitancy if vaccine hesitancy is understood to be signaling much broader discontent and much broader issues that need to be addressed around historic and contemporary mistrust.
That if I can comment briefly, that fits also with the sense that I had as you were describing a shift to the crisis of trust framework, how the sort of fixes that are then called for are much bigger sort of challenging things to accomplish. And so this sort of hinted at this sort of a response as well. Okay, so Sean Barrell asks, is this question on the proliferation of expertise unique to this contemporary moment? Or haven't there always been outsiders, such as traditional medicines, quote unquote, traditional medicines, shamans, etc.?
There have always been alternative experts. However, we seem to be at a moment of higher. So this I will agree when people talk about the death of expertise, even though I largely challenged the way it gets framed, I will agree that public trust in experts seems to be lower. They do all kinds of national and international surveys that show this. Where in sort of the last, let's say, few decades, you see a lowering in public response and positive response to experts. There were times when the white lab coat was far more trusted than it is now. So sociologists sometimes point to the post-Second World War economic boom in the US as a time when science was kind of, people were awestruck by science. This was a good time, new vaccines, launching things into space. So this was a time when people had a very high attitude, a very positive attitude towards science, and scientists were well respected. They were often called on to speak outside of their domains of expertise. Now we have a much more truncated understanding of what counts as an expert. So just because you're a medical expert doesn't mean you're an expert on many other things. And that's probably the right way to think about expertise. But it is well tracked and well known that we are at a low point in terms of expertise. And I think it speaks to some of the concerns about science and power that I've tried to address, that the corporatization of science has created the concern that perhaps science is not always being done in the interest of the people. So now we talk about financial conflicts of interest. We've got COVID vaccines that cannot be produced and distributed fast enough to the developing world because patent protections keep that from happening. So that's the kind of narrative that is becoming all too common in commercialized science, where science is supposed to be something that is for human benefit and social good, and it doesn't always appear to do that.
Helen Miskitsi asks, given how closely related people's positions on vaccines are to their general ideology, to what extent is it possible to address vaccine hesitancy in isolation? That is, to what extent can interventions be done by doctors, physicians, et cetera, just focused on that? How can those be successful?
Well, there's been some interesting research and even some public campaigns around vaccines that try to break down the connection between certain ideological views and vaccine attitudes. So, for example, there was I discuss in the book a campaign that took place in Western Australia in a very sort of natural living kind of, we could call it a hippie community, a demographic that was sort of apparently similar to Seattle, where people were largely vaccine resistant. And members of the community, so this was community-led, created these posters and websites where they told narratives, people in their community told narratives that affirmed the values of the community, but also included vaccines as a thing that they do. So you'd see these posters that said things like, I grow vegetables in my backyard, I only use cloth diapers for my children, and I vaccinate. So what that kind of campaign did, and it was measured and had some effect, is that it broke down that connection between certain worldviews and attitudes around vaccines. So if you can kind of break that narrative, where you can show that, let's say, a Trump supporter can feel good about about COVID vaccines, or someone who really values natural living can vaccinate and still feel that they're, living to their principles, well, then you've got much more opportunity for engagement around vaccines. because vaccines have been tied to these kinds of ideologies and worldviews, and breaking it down is a way that you can change attitudes around vaccines.
Thank you. So given that we are approaching 8 o'clock rapidly, maybe we're there, but I'm not going to believe that. I'm going to make the difficult call to choose one more question. So apologies for the people who I haven't been able to pose your question for you. So our last question is from Nicholas Krauss. There's a difference between distrusting science or information around science and rationally questioning science. Considering your work in philosophy of science, where do you draw the distinction between the two, and how that distinction relates to vaccines?
Well, rational mistrust, yep, or questioning and skepticism, yes, we agree that that's a good way of operationalizing your relationship to science. Distrust, if that means some blanket refusal, well, it is true that you may not get very far with people who really hold to that view. Even public health research into vaccine hesitators recognize that there might be pockets of the population that are so insistently against vaccines that you may never be able to reach them. Fortunately, that extreme view is not widely held. Most people are somewhere else on the spectrum where there is room for consideration, because most people think that science and medicine have some value in their lives. You very rarely meet the science denier, only alternative medicine would not touch anything like a vaccine. And the truth is, as long as those numbers stay low, as long as that attitude is not a common one, that's okay. We don't actually need to vaccinate everyone to get the kind of community protection that we're looking for. We need a lot of buy-in, but we don't need all of it. So I see no harm in saying there will be some people that you will never reach, and that is okay.
That's helpful. And also a nice stopping point. So before we stop and before we end, I want to, first of all, remind everyone that there's that handy button at the bottom that will take you to a page of the Center for Public Engagement with Science's website, where you can get different buttons for different ways of purchasing Professor Goldenberg's book, as well as find out more about our Center for Public Engagement with Science and join our email list if you want. Thank you so much, first of all, to the audience for joining us, for everyone who could join us. I really enjoyed seeing where everyone was from and names as well in the chat through this conversation. Thank you to the Mercantile Library for hosting this conversation. It's really been fun to be involved with. And of course, more than anyone, thank you, Professor Goldenberg, for sharing your insights and giving us this interesting window into this book that you've written. We really appreciate your time.